Hello and welcome to Filibusters in Fine Print, where AMGA's public policy team gives you the insider view on healthcare regulations and legislation. Thanks so much for joining us for the latest from Washington, D.C.
Good morning and welcome to Filibusters in Fine Print, AMGA's public policy podcast. I'm here with the AMGA public policy experts, and why don't we introduce ourselves?
Good morning, everybody. My name is Daryl Drevna. I'm the Senior Director of Regulatory Affairs.
AKA Diva 2.
Alicia Sawyer, Government Relations Assistant.
Jamie Miller, Ambassador Goodwill, and I don't know if you watched SNL, but I didn't realize it was sweater weather. So, sweater weather? No? Okay.
No.
Do you know what I'm talking about?
Yeah, I do.
Okay, thank you.
I do.
Do you? Okay.
I don't want him to know that I know.
Mike, do you? You do too?
Maya Rudolph and Amy Poehler.
Okay, apparently. All right.
Sorry.
All right. I'm out as usual. What a shock. But I'm wearing a sweater. Is that bad or good?
It's good.
Okay.
It's sweater weather.
It's sweater weather. It's cold enough outside. It's sweater weather.
Oh. Okay. This is deep.
Thanks for backing me up.
Yeah, you're welcome.
Deep and substantive stuff. Fantastic.
I came to play today. I came ready.
Well, we are making up for Diva 1. Miss Latney is not with us today.
She's on a day trip
She's
to
alive.
Nashville.
She's alive.
There and back in a day.
She's an executive.
Yeah.
Yeah, her time is valuable. So
I'm sure she's flying private, right? Is that?
That's the AMGA way.
Yeah.
Because we got that kind of cat.
Yeah.
AMJ ways we
So we're
sit
gonna
way
talk
in the
about
back
this.
next to the bathroom.
3080.
The whole health system just flush with cash, as we're going to talk about.
Middle of the road, whatever's the cheapest, because we care about the dollar.
There we go. Good. I have a question for the group today. Can you guess what it is?
No.
No? Okay.
I can't.
What is the second longest continuous brick building in the world?
Second long. I think this is an Alicia question.
Yeah, as it is Doak Campbell Stadium. That was a fun fact I shared this morning. FSU Stadium is the second longest continuous brick building in the world, second only to the Great Wall of China.
Well, there we go.
Sweet.
So we need, what are those things called? Paragon? Not Paragon. Patreon.
Oh,
So you all
right.
can watch the behind the scenes stuff when we talk about things like that. Okay. Well, let's get going. And yeah, no one else knew that answer except for Alicia, so thank you.
You're welcome.
Proud FSU grad.
I am.
You are. All right. So guess what? Today we're going to talk about, well, let me back up. Daryl is smiling ear to ear. One, because Lauren's gone. And two.
Wow.
Well,
Shots fired.
Well, Diva 1, Diva 2. I mean, he's got it all to himself.
Where's the sound effects? Shots fired.
Oh, please don't do that again.
Even Michael's going to shut this off. So Daryl's here. We're going to talk about the 2026 physician fee schedule.
Final rule.
Which came out on October 31st at 5:15 p.m. on Halloween.
Halloween.
Yeah. Really nice of them, isn't it?
Everybody in Reg World was thrilled as we're taking our kids out for whatever Halloween events. Like, oh, wait, CMS tricked us. You know?
They do that every year.
They do.
I believe they release some things on New Year's Eve as well.
They have.
Yeah. Very kind.
They're fun that way.
All right. So the fee schedule, I'm looking at Daryl's 4-page outline. It represents another year, an ongoing crisis for doctor reimbursement, which is true. There's some modest relief this year in the final rule, but there are systemic issues with physician fee schedule in Medicare. Is that true?
Very fair.
Okay,
Yeah,
very good.
fair.
All right, I tell you what, let's talk about some of the provisions within the rule because it's really important to the members. As I understand it, CMS finalized 2 conversion factors for 2026. Why 2, and what are they?
Sure. Yeah, this is a new requirement. It's part of the transition to value that macro is intended to sort of support. And beginning in calendar year 2026, 2 separate conversion factors, one for qualifying alternative payment model participants and one for physician practitioners or physicians that are still in the MIPS program. So if you're an APM, you're qualifying practitioner, you're going to get a 3.77% bump over the current year, and it works out to $33.57. We'll round up a little bit. Mm-hmm. And if you're a non-QP, it's $33.40, which is a little bit less of a bump, 3.26%. So it's still an increase over the current year. You just get a little bit more of a bump if you're a qualifying practitioner. It's the first increase in 6 years that CMS has finalized. It's been a number.
That's an incredible fact.
It really is, yeah. So it's been cut after cut after cut, and most of it is due to what Congress has done or not done.
Yeah, and Congress intervenes kind of at the last minute around Christmas time and does, like you said, a patch, but that patch doesn't always make us back to whole. But what happened in December of 2024 was AMGA worked on a patch for 2025 calendar year, and that bill did not end up passing into law for various reasons, and there were a lot of other factors involved in that bill. So for 2025, there was no update there through Congress, a patch. And so this 2.5% update that we passed this summer for 2026 is nice, but like you said, it's not really keeping up with the cost of care.
Right. So I expect, if we fast forward to when the proposed rule comes out in, June, July of 26 for the 27 year, it's going to be a cut again, just the way things work out, just the way the formula works.
Okay. So we have 2.5% increase that was passed by Congress. That makes up part of the 3.5% increase for, on average. Where else do these increases come from for the conversion factor for this year?
Where else does this come from? Mm-hmm. It's just the budget neutrality way the fee schedule works. CMS will take a look at, how physician payments have increased or decreased, how they're shuffling various coding and all that, and it spits out, the formula will just spit out what the conversion factor is going to be, and that's, you put it into the CMS-O-Matic and it spits out these conversion factor numbers. So, it's really, there's that, congressional intervention, the statutory updates, the 0.75% for QPs, 0.25% for non-QPs, and then the almost 0.5% budget neutrality adjustment, and that's really what formulates. Yeah.
Okay. Great to know. Okay, so we have two conversion factors for the first time ever.
Correct. Yeah.
Because of the macro statute requires it. What other major policy issues are in this rule? Because there are a few.
I think one of the big ones everyone's been talking about is this efficiency adjustment. And funny enough, it's a minus 2.5%.
For being efficient.
Okay. So CMS thinks like, hey, as you get more familiar with services, as you gain professional experience, as technology improves, as your operations improves, CMS expects non-time-based codes to simply become more efficient. So, we're going to pay a little bit less. So for non-time-based services, CMS is implementing this, minus 2.5% adjustment. Does it apply to time-based codes such as like E&M services, evaluation and management services, care management services, behavioral health services, things along those lines?
Okay. So primary care is sort of exempted from this.
Yeah.
This is more of a specialty.
More of a specialty type thing. As you can imagine, they're thrilled beyond words.
Sure.
Yeah.
And I think we're seeing some correspondence among the AMGA members on our listservs about how they're going to handle this new efficiency adjustment.
Yep.
All right. There's another big change in the rule.
Yeah, the practice expense, the indirect practice expense reallocation, and this is one of CMS's efforts really to implement some site-neutral policies. There's a 50% reduction in the practice expense allocations for facility-based services. It's a mouthful.
Yeah.
So essentially, if you are providing outpatient care under the physician fee schedule in an outpatient setting on campus, they're going to reduce your rates. And you can look in the back of the rule, and it's, -5, -10, depending on what the specialties are. Please don't ask me to give you an example because I don't have one off the top of my head.
I think I saw, if I remember correctly, gastroenterology is a -14% hit in a facility setting.
Yeah.
I do remember that. You had a good slide on that.
I did. So, yeah.
Which no one can see. So I don't know why I mentioned
should have
that.
printed that out.
If only we had cameras.
All right, yeah, Mike, when we get cameras, we could have showed it. This is a production problem. But we troop on.
So on a side note, today's New York Times has a whole thing about how to shoot and produce podcasts and how they're supposed to be very casual and the settings are kind of junky. So I think we're right on trend.
Minimal.
Exposing ourselves a little bit there.
You should see our room.
Yeah.
It's a nice gray bed sheet. Got up there. Yeah,
exactly.
Yeah.
Exactly.
Production value.
Homey.
Homey, right. Very good. Okay, well, thank you. There's also some telehealth changes, I believe, in the rule.
Yes, some of the Medicare telehealth policies were made permanent in the final rule. This is separate from the telehealth flexibilities that AMGA has been lobbying on regarding geographic and originating site waivers. So this is separate.
So you're saying Daryl did his job. The lobbyists have not.
Lobbying is a continuous,
It's like,
ongoing
what else is new?
effort. Whoa, I did not.
More shots fired, I reckon, I guess.
Okay, so Lauren leaves the
team's falling
bathroom
apart.
and it can help be filled.
Yeah.
She's the
Apparently.
glue. I had no idea.
There's lead
So
drag tension apparently.
Daryl
Because
fixed
we
it.
love.
Daryl fixed it. We're lobbying. We're working on
We
it.
only fix some things. Not everything.
Not everything.
This is
This is good. I like this. It's good. Yeah.
Some of the things that were made permanent, I'm going to move on now. Get to what I want to talk about. Virtual direct supervision was made permanent for incident to services. Teaching physicians can virtually supervise residents in all settings now. And there were changes to remote patient monitoring with new shorter duration codes that were finalized.
all right. Well, thank you for that. Daryl, a new model was also included in the rule.
Right. So this is the ambulatory specialty model, and this is it's a mandatory model, and it makes specialists financially accountable for patient outcomes if you're treating Medicare beneficiaries for low back pain or heart failure in outpatient settings in selected geographic areas that have yet to be named. And they're picking these two conditions largely because of the costs associated with treating them. I think heart failure is a $10 to $13 billion annually Medicare spend. Low back pain, $6 to $8 billion annually, and those are some of the most costliest conditions for fee-for-service Medicare. So they're going to create this specialty model, and the idea is we're going to increase collaboration between specialists and primary care providers, improve chronic disease management. And, really it's if you're treating these conditions, you're going to be accountable for the cost and quality of the care. Now, the issue here is that it's a really low threshold to clear if you're going to be included in this. If you treat 20 patients, you're going to be wrapped into this model.
20 patients.
20 patients. And that's really... We push back against this because it's hard to have any sort of statistical validity in what you're doing with an N, or sample size of 20.
Right. That does seem hugely low.
Yeah. But to see CMS's, they see those numbers. They're not worried about the 20. They're worried about the 10 to 15 billion or 6 to 8 billion for those conditions, and that's what they're focused on.
All right, well, that'll be interesting. That'll be TBD, and I'm sure we'll have more comments about that.
Absolutely, yeah.
As 2027 comes around. Okay, so we talked about some of the specific provisions in the final rule. What are some of the fundamental problems with Part B reimbursement?
Well, I think relying upon Congress to intervene every year doesn't work because obviously they didn't intervene in 2024 for 2025 calendar year. And this is one of the only schedules within Medicare that doesn't have an inflationary update. So I think that's just an inherent problem across the board. And as Daryl mentioned there, that 2.5% boost is nice, but it barely rebounds from the current fee schedule from 2025. So this is just a long-term erosion of Medicare payments that are not keeping up with inflation.
I think one of the other issues that really comes out of this year after year is this budget neutrality problem that's baked into the fee schedule. So, any changes need to be revenue neutral year over year. So if you're going to increase, a couple of years ago they wanted to plus up primary care. So that means somewhere else on the ledger's got to go down. And it creates this zero-sum game among all the various specialties. So it's, everyone's costs are going up. And the fee schedule just doesn't recognize that, to Jamie's point. There's not that inflationary update. And if CMS is like, we need to increase some payments on here, that means someone else is going to get whacked, essentially. And it really is an unfair arrangement that doesn't really account for the actual expenses that clinicians and physicians are facing on the ground.
All right. And so you mentioned cuts. So Alicia, what are some of the cuts over the past few years so that the members remember where this is going or has it gone?
One of my favorite things that I get to do with our Stop the Cuts campaign is I work on an infographic. And so previously we've done an iceberg where we have like the cut for the 1 year and then all of the cuts for the preceding years beneath it. Or we had a tidal wave with all of the cuts. And that's what this is. So 2021, there was a 3.3% cut. 2022, there's a 0.8% cut. 2023, there's a 2% cut. 2025, there's a 2.83% cut, which was partially mitigated by Congress, but then in 2026, there would have been another cut without congressional intervention, but it's just one on top of the other. It's just the tip of the iceberg. We're dealing with years and years of cuts just compounding on top of each other.
Yeah, we use the word unsustainable, and hearing you list these cuts out, that makes sense to us. Jamie, what are we doing about this?
We're, House and Senate leaders who are concerned about these cuts, and when we're advocating, we're not talking exactly about provider care and the compensation. This is about patient getting access to care. So we had Representative Miller Meeks last year, who's a doctor, a GOP Dog Caucus member. She led a letter with 232 House members signing a letter to leadership saying we need to stop this. There's been other pieces of legislation basically trying to prevent this because every member of Congress agrees they don't want Medicare patients losing access to care because beyond the moral aspect of it, there's also a political problem when these people who have paid into the system are not getting access to their doctor. They're going to be calling every day complaining about it.
All right. And there are real-world consequences because of these cuts over time.
There are, and Jerry Pence, our CEO, has been out in the press talking about this. He's said like the health systems are really bearing the brunt of these like outdated and underfunded reimbursement models, and I think if you keep on this path of systematic underfunding of care, you're going to see practice closures, especially in rural or underserved areas. Like what can't go on forever just won't.
Mm-hmm.
Yeah, it threatens access to care for Medicare beneficiaries because providers are forced to take drastic actions just to be able to keep their doors open. We do our 2020, we do a Medicare cut survey as part of our Stop the Cuts campaign, and in 2025 we did a follow-up survey to see what actions AMGA members had actually taken, and it was kind of chilling because just to stay open, they're looking at all kinds of things, and I mean towards the end, like some of them are looking at potentially not being able to take new Medicare beneficiaries, and nobody wants that.
Nobody. And even in D.C., I know my father had to see a cardiologist, and he had to wait 6 months.
It's a long time to see a heart doctor.
Yeah, it is. It is. Yeah. Luckily, he's paratrooper CIA. He didn't care.
But
some people do. So
eating nails for breakfast.
Sort of. All right. So we're not complaining about this. We are actually doing some things. Is that right? What are we up to?
Yeah, so we have some actual policy recommendations, and I think it's this push for systemic reform. Like we've got our macro and value task force, which looks at the need for sustainability in the Medicare program. So let's tie the conversion factor updates to the actual cost increases, like tying it to the Medicare Economic Index. Let's move away from this budget neutrality driven cuts that you can either increase the threshold of what budget neutrality gets triggered. Right now it's so low, it's $20 million. Mm-hmm. You're talking about a $60-70 billion program. Like $20 million is not even budget dust when you're talking about numbers like that. We can look at eliminating the low volume threshold in MIPS so more clinicians participate and you actually get some meaningful updates. And then really take a look at the program as a whole instead of siloing it into, here's what we're going to spend on Part B, here's what we're going to spend on Part A. And if you save on one side, that doesn't really factor in. Like if we spend a little bit more on Part B and save on Part A, the system doesn't really account for that.
Okay, fair enough. And that's part of the Medicare Task Force, which you directed.
Yes. And we're Dr. Hines,
Yeah.
yes. We've got a lot of great ideas, and we've rolled that out to the Hill, and we're going to do a big media splash around it. So pretty exciting stuff.
In 26.
26,
yeah. That'll be our offensive legislative proposals for 26 and also 27. Yeah. Okay, we mentioned our recommendations. Other legislation around, Jamie?
Yeah, the GOP Doc Caucus, Greg Murphy, who's a physician in North Carolina, has a bill strengthening Medicare for Patients Access and Providers Act. I think, as Daryl mentioned, we don't want to just patch it up and stop a cut. We want to tie everything to inflation. So his bill ties everything to MEI. And also, on the MEI issue, there was a provision in the House-passed version of OB3. It got stripped, but there was a provision where Congress is starting to discuss MEI as a part of the fee schedule instead of just saying, let's stop these cuts. Also, when Daryl mentioned the $20 million budget neutrality trigger, there's a bill out there called the Provider Reimbursement Stability Act that tries to increase the cap to $53 million. And I would say also the way we communicate this to Congress is this really shouldn't be called the Medicare Physician Fee Schedule. This should be called more the Medicare Ambulatory Services Fee Schedule, because this isn't about compensation. This is about more accurately reflecting the broad spectrum of healthcare providers reimbursed under the fee schedule. And this is about nurses, PAs, NPs, other things. So, this isn't about, like I said, there's many things that dictate compensation, but this is about providers and getting access to care and being paid for the services they provide.
All right. Fair enough. Thank you. We are at 21 minutes, so we got to wrap this thing up. Any final takeaways from our expert panel?
Yeah, the 2026 rule, it's just temporary relief. It doesn't come anywhere near solving the systemic problems that we're looking at.
All right.
Yeah, and I'm hopeful that, as we really start pushing on this, Congress and policymakers will understand and appreciate the need for predictable, sustainable payment updates in what I'd like to call, Jamie's point, the ambulatory fee schedule.
Mm-hmm. And this issue is not going away. The gray wave in America is dramatically impacting the Medicare Trust Fund. So there's going to be constant conversation about this for years to come.
That is true. All right. Well, I guess that's it. Outstanding topic, Daryl. Well done. Fantastic outline. Very happy. Miss Latney's probably just shuddered.
Yeah.
When she heard that.
But your move, Lauren.
But as always, we thank our listeners for listening in, and you all have a good day.
Thanks for joining us for Filibusters in Fine Print. This podcast was brought to you by AMGA. For more information about AMGA's advocacy efforts, visit amga.org/advocacy.